is often multifactorial. Okay. So what is the pathophysiology of delirium? There are a lot of different theories. So I'll just kind of share a few of them. But basically, it's thought that functional connectivity between the suprachiasmatic nucleus and other structures can be changed. It's also noted to be a pro-inflammatory state. There's potentially some breakdown of blood-brain barrier, which can increase susceptibility to toxins. So potentially maybe that patient's benzos may have affected her more. And then there's also kind of like a neurotransmitter imbalance theory where it's a hypocholinergic, hyperdopaminergic state. And then there's also thought to be some like disturbance of a person's suprachiasmatic nucleus, like I mentioned. And the importance of that is it's kind of like the biological master clock. So that can kind of explain like the variability. And some of these folks do stuff such as sundowning. Okay. And also to note, there's a theory with the pro-inflammatory state, you have more like cytokines that may be contributing. And I really liked this quote. It was taken from a systematic review in neurology. But it says, delirium can be conceptualized as a final common pathway resulting from multiple factors that lead to a state of impaired brain function. Just kind of highlighting that there's a lot of different theories, but there's a common pathway that kind of leads to what we can diagnose with the DSM-5. So this is kind of going more into that review, and it's looking at predisposing and precipitating factors associated with delirium, which I'm going to spend a fair amount of time talking about because delirium is like so multifactorial, and it's really challenging to kind of like put a finger on what predisposes someone to it and what actually causes it. And more importantly, understanding delirium is a major unmet need. It's associated with adverse outcomes, including risk of falls, functional decline, dementia, prolonged hospitalization, institutionalization, and death at an annual cost of $38 billion up to $152 billion in the United States. So delirium is very common and costly. So going back to this review, they looked at 315 studies, and they looked at a mix of cohort and case control studies that were conducted between the early 90s and 2020. They all told, among those 315 studies, they looked at a total of about 100,000 patients. And they, from all of this, said it was etiology of delirium was heterogeneous, but they were able to identify 33 separate predisposing factors and 112 separate precipitating factors. In terms of their 100,000 patients, they did a really good job of having almost 50-50 male to female patient, or male and female split. They didn't mention any alternative gender identities, so I can't really comment on that. They also did not comment on the race of the subjects. However, they did include data from 40 countries. Although still among those 40 countries, data were primarily from the United States. And then this study, for most of what they looked at, was hospital settings, up to 98%. In terms of collecting data, so since this was a systematic review, the authors of this particular paper weren't choosing the assessment of delirium, but most of the studies that they looked at used something called CAM, or Confusion Assessment Method, which I'll show you in a second. It looks like there's something in chat. Could you please elaborate on the assumption of the involvement regarding the suprachiasmatic structure? Did you mean pathophysiologic? So I think, honestly, I can't really elaborate. It's been noted that there can be a change in functional connectivity, and that the suprachiasmatic nucleus is involved, but I don't think that I actually know enough depth to answer that, so sorry. So going back to the CAM, this instrument was translated from English into many languages, and it's fairly sensitive, up to 100%, and specificity is 90 to 95%. And I'm kind of just showing this because I think that the way you assess delirium determines like the results of your study. So since the CAM was used in most of these studies, I think it's important to go through it. So this is just a screenshot of what they're looking at in the CAM. So the first item on it is whether there's evidence of acute change in mental status from the patient's baseline. The item number 2 is looking at inattention, like are they easily distractible? And then if it's present, like inattention is present, then does it fluctuate during the interview? Does it change in severity? Item number 3 is looking at disorganized thinking, like are they having a rambling conversation? Is it irrelevant? Is the flow of ideas illogical? Item number 4 is looking at altered level of consciousness. For instance, are they alert? Are they vigilant? Are they lethargic? Are they in a coma? Item number 5 is disorientation, and that could be at any time during the interview. Item number 6 is looking at memory impairment. Did they have inability to remember events in the hospital? Could they not remember instructions? And then down the list, item number 7 is perceptual disturbance, such as hallucinations. Item number 8 is psychomotor agitation during interview, like are they fidgeting? 9 is altered sleep-wake cycle, such as excessive daytime sleepiness and potentially insomnia at night. So this confusion assessment method was used in most of the studies trying to get at predisposing and precipitating factors of delirium. And then the CAM has an algorithm for scoring those different features. And importantly, just as a broad thing, you have to have acute onset and fluctuating course, plus inattention. Sorry, I think I'm saying this wrong. You need either features 1 or 2, which is acute onset or fluctuating course and inattention, and either disorganized thinking or altered level of consciousness. So the acute onset is key, inattention's key, and you can have either disorganized thinking or altered level of consciousness. Okay, so looking at all of those studies, out of the 33 predisposing factors that they identified, the top 3 were advanced age, that was seen in 112 of the 315 studies, cognitive impairment or dementia, that was seen in 130, and then third was functional impairment, which was seen in 48 out of the 315. And then they identified these factors using multivariate analysis. So factors that weren't in the top 3 included male sex, multiple medications or polypharmacy, and the use of psychoactive medications. And then just kind of looking at other things, race was not identified as a predisposing factor. Okay. Precipitating factors gets a lot more complicated, and there were 112 factors that were then grouped into 8 subcategories. And so those 8 subcategories are surgical factors, pharmacology, iatrogenic and environmental causes, trauma, biomarker abnormalities, levels of neurotransmitters, systemic illness and organ dysfunction, and metabolic abnormalities. And then just because it can be kind of confusing when they're talking about metabolic abnormalities, they mean like hyperglycemia or hypoalbuminemia. And for the neurotransmitter thing, they're kind of looking at like high CSF or serum tryptophan or like low serum acetylcholine. Surgical factors, when they're talking about that, they mean like, did the patient have an emergency surgery or a cardiac surgery? And pharmacology, I think we kind of touched on earlier, which is fairly self-explanatory. So looking at all of these subcategories, for pharmacologic factors, primarily medications that we use to manage behavioral symptoms of delirium actually show up as factors that are causing delirium. So not so much benzodiazepines in terms of things we'd use to manage delirium, but certainly neuroleptics and anticholinergic medications. They also noted that sedatives or analgesics and opioids are some pharmacologic factors that are associated with delirium. In terms of preventive measures, cognitive reserve was noted as the most robust protective factor. So patients with high vocabulary scores and patients who were able to get frequent engagement in social activities, it was found to be protective. So kind of thinking about, I think case number 2, where the patient, sorry, there's something in the chat. Is post-surgical delirium attributed to adverse reaction to anesthesia? I don't believe so, no. I think that they were just kind of lumping people into a whole, like if they had surgery and then developed delirium, since they also have a separate psychopharmacologic category, which I think that would be a part of, but I'm not 100% sure. So I think the big question is, should we treat delirium? Because, you know, based on this study, the things that we use to treat delirium can also increase one's likelihood of developing it. And so my question to you is, if patients in psychiatry have increased predisposing factors and are tools to manage symptoms of delirium simultaneously increase the risk, how do we manage the symptoms of delirium? And so like looking at case number 1 that I presented, that was the patient with pneumonia and the TBI. They were treated with antibiotics, and then they received olanzapine that was recommended by PsycCL. But was it beneficial to that patient? So I wanted to look at antipsychotics for treating delirium. And this was a systematic review, was in Annals of Internal Medicine. And they looked at 16 randomized controlled trials and 10 observational studies. And there they were looking at Haldol and second generation antipsychotics versus placebo. And as a note, although they're looking at Haldol and second generation antipsychotics, nothing is FDA approved for treatment of delirium. Although some folks have posited that antipsychotics may reduce symptom severity. So these authors concluded that there was no difference in symptom severity and cognitive function when they looked at Haldol versus a second generation antipsychotic. And there was insufficient data to conclude whether antipsychotics were beneficial versus placebo. Alternatively, there was little evidence that neurologic harm was associated with short-term antipsychotic use. And overall, they suggested that evidence doesn't support antipsychotics for delirium in hospitalized patients. But this is kind of a very unsatisfying result because it's basically inconclusive. And these authors also noted that the dosing, like since they were doing a review, dosing of antipsychotics was like not consistent across studies. So that could have been an issue that they were looking at. And they also noted that measurement instruments were inconsistent. So, you know, maybe potentially if everyone had looked at using the CAM to identify patients with delirium, this wouldn't have been an issue, but that is not what happened. So even looking farther into this, another question is, can antipsychotics prevent delirium? So a different study in the same journal looked at 14 randomized controlled trials in a systematic review. And they concluded that there was kind of limited evidence that second generation antipsychotics could lower delirium incidence, but only in post-op patients. So they weren't looking at just like everyone in the hospital. And they concluded that in general, the evidence doesn't support Haldol or second generation antipsychotics to prevent delirium. It kind of looks like I've rushed through this since this is actually my last slide. So sorry for talking at you so fast. But honestly, having looked at several different studies on delirium, I came away from it with only a few conclusions. The first of them being that delirium is heterogeneous, and theories for cause of delirium generally include a person with like a predisposition plus having an insult such as illness or medication use. Delirium is a constellation of symptoms defined by DSM-5 criteria and caused by acute encephalopathy. So I think it's important to note that acute encephalopathy is different than delirium because it is a rapidly developing pathobiological process, and it frequently causes delirium, but delirium is characterized by the acute change in attention and awareness, and it's always got a medical cause, which is my next point. Delirium always has a cause. And then based on the one study that looked at, you know, almost 100,000 patients, the causes of delirium are extensive and probably unique in almost every case. And unfortunately, treatment and prevention are unclear, which is really unfortunate on a societal level, since delirium is literally costing, I think it was like on the level of billions of dollars, and affecting a very high proportion of patients. And then for folks in behavioral health, I think this is especially important to look at, since we are often prescribing medications such as benzodiazepines or antipsychotics that can be associated with causing delirium, even when we're trying to treat the symptoms of delirium. So I think we have this, we have an extra issue where the treatment can also be a cause. So with that, I'm going to bring you to the last slide, which is asking for your thoughts, conclusions, and questions. I'll do my best to answer, or maybe folks in the audience can answer.
I think there is a question in the chat box.
As far as environmental treatment is concerned, seclusion of the patient may be very helpful. Sorry, can you explain what you mean by that? Oh, do you mean like managing the setting, like making sure that you've got the blinds pulled? Gotcha. Yeah, I think that's a really good point. Like we do know some risk factors for delirium. So, you know, if you have a surgical patient, then we should be making sure that we try to keep their circadian rhythm on track. I think that's a really good point. Thank you for bringing that up.
Thank you, Dr. Tessa, for such a wonderful, informative presentation. We truly appreciate that. Now the floor is open for question and answer. If anyone has question for Dr. Tessa, please unmute yourself or put it in the chat. Otherwise, I can end the presentation, and thank you once again for joining us or attending for this presentation.
Awesome. Thank you all for paying attention and your wonderful questions. I put some references here. I also wanted to recommend, if you have time, there is a Nature review paper. It was done in 2020 by Wilson et al. And it's a really quick overview of delirium, talks about all of the potential causes, and highly recommend it.
And I also shared the CE survey links. Please copy that link and complete your survey in 48 hours before the links become inactive. I'm giving 1 or 2 minutes extra so that people can copy that link.
Also, thank you for pointing that out. Yes, one of the things that can cause delirium is withdrawal from substances, not just the substances themselves. And this is the link for evaluation. You can either use your phone to scan it or click the link, or try to click the link below. I'm not sure if it actually clicks.